The last talk of the day would be acute and chronic rejection and liver transplant, the clinician's perspective, to be delivered by Dr. Joy Varghese. He is the Director of Hepatology and Transplant Hepatology at Gleneagles Global Health City Hospital, Chennai. Over to you, Dr. Joy.
So good evening to all. Can you share my slides? Yes, I'm not getting options.
Yes,
here.
please.
Thanks to Dr. Sanjeev Saigal and the very fantastic the transplant hepatology course. Okay, and it's the discussion is going very well. And I'm waiting for to get the option for the to share slide. Otherwise, I already sent my slides there. Can you? Yeah, that's fine. Thank you. So now the practical point of view, the clinician's perspective, I wish to talk. Next slide, please. It's not moving. I think you are controlling. Yeah. See, how to diagnose, that is the important key in the clinicians. So acute rejection, we know whether really we have to do the liver biopsy or not. So particularly in Indian setting, particularly the immediate post-transplant patients, they will be the drying tube, they will be on the antiplatelet, anticoagulant sometimes. So whether to do the liver biopsies, I mean, to confirm the ACR, that is the question. So normally, as a team people work, they have to collectively take a decision. We should rule out what are the possibilities of the elevated liver enzyme. And if we come to conclusion that clinically it looks like a ACR, without liver biopsy, we can go ahead for the treatment. This only applicable in immediate post-transplant, the living donor liver transplant setting, because of the lot of the other issues. But at the same time, if the patient comes 6 months later or 3 months later, if they have the elevated liver enzymes, of course, we should rule out all the possibility of the biliary issues or sepsis, etc. And definitely we should go ahead for the liver biopsy. With the liver biopsy, we can go ahead for the treatment option. Then how to treat? What is how we have to treat the patient? That's also. Tacrolimus level is the key. We should look into that whenever there is a rise in liver enzyme. Even though it looks like a rejection, we no need to jump into the immediately either the biopsy or the pulse therapy. If the patient has the slight elevation in the liver enzyme, AST, ALT, that time, if you look into the tacrolimus level, it is lesser than the therapeutic target, then we can increase the dose. And in the meantime, anticipating that sometimes bringing the tacrolimus level will not help to the patient. So we can tell to the patient to withhold the antiplatelet agent, because most of the transplant recipients will be an antiplatelet agent. Suppose if we have done the Budd-Chiari syndrome, some surgery, that time the patient will be an anticoagulant therapy. So first of all, we have to look into that. If the adequate lac level is there, then the question will come, how much the methylprednisolone we can give, either 1 gram or 750 or 500. This also will vary based on the patient condition. If you know, the post-transplant patients recovered from very sick condition or due to the already sarcopenic or multiple level of sepsis and other things, that time, even though it looks like a ACR, we no need to give, because these are practically we learned, we no need to give the routine dose of the 20 milligram per kg body weight per day for the 3 days. We can give the low dose, either 500 milligram, and we can see the response. And in case if we have a suspicion of the sepsis, we should rule out. We know we have to rule out, and we can give the proper antibiotic, and then we can manage with that steroid therapy. The duration also, some of the center will give the 1 gram with the 3 days, or some of the center will give the 500 milligram for 5 days. That all will vary. Everything based on the immediate post-transplant. Suppose the same thing as again telling, the patient comes to the acute rejection in the later on, in the 3 months or 6 months later, better is we can give the 1 gram of the methylprednisolone for 3 days. That will be the ideal option. Then, whenever we are giving that pulse steroid therapy, we should keep the optimal level of that tacrolimus level or cyclosporine and also the MMF. We shouldn't bring down the level, because this all then it will lead on to the, even after pulse therapy, the patient will get again and again the rejection. And how long we should give the continue the steroid therapy after the 3 doses of therapy. And we know to reduce taper the dose of the steroid, normally in 1 month, but that also will vary. If the same patient, the biopsy, if he shows the de novo autoimmune hepatitis, or if the biopsy, if the patient we operated for the PSC or a PBC or autoimmune hepatitis or the overlap syndrome, so or the patient with the recurrent ACR history, that time we should continue the low dose of steroid for the rest of the long term. Okay, we shouldn't stop the low dose steroid immediately. Otherwise, it will go for again and again rejection. Next slide, please. Yeah. So this is the one question normally we all the clinicians have it actually. What is the yearly ACR, whether it really good or bad? Because earlier one paper came based on the yearly ACR, if occurs, it will give the good immunity to the liver and the graft function will be good. But after that, there is no much paper. So what as a clinician, we can understand whether it is a yearly ACR or the late ACR, we should treat the patient. And if you look into the long term, there is no proof for the giving the immunity for the long-term benefit. What will happen if the patient have recurrent ACR? We are giving the optimal dose of the tacrolimus and we are maintaining the adequate, the W immunosuppression. But still, if the patient, even though they have the good complaints of the drug, and if coming again and again ACR, there are more chances to go into the chronic rejection. So this in general, actually, we no need to get the alarm for the ACR because there are the literature, we know the 40% of the people, there is more chances to get the ACR. But if you look into the literature, there are the literature already published, even 70% of their own, the center related, the patients recipient have the ACR. So it is a vast 40% to the 70% of the people, there is a more chance to get the ACR. So we know if the patient get the ACR, we should treat, it is completely reversible. If there is no response to the pulse therapy, then as the clinician, it is a really challenging. So what next we can do, as I already mentioned that we should, in the day one itself, we have to maintain the adequate tacrolimus level and patient should be on the MMP supportive, not only the tacrolimus and the steroid. And still, if there is no response, we have to repeat the biopsy to reconfirm it. Really, it is a steroid-resistant ACR. That time, now the mTOR role is coming. So the mTOR plays a major role nowadays. In practice, we are seeing either the patient, the partial response with the steroid pulse therapy or the recurrent ACR or even yearly chronic rejection, the mTOR usage along with other immunosuppressive therapy, it's going to be bringing back the normal liver function. And still, if there is no, the liver function deteriorates, we have to consider for the ATG. Next slide, please. And this is a chronic rejection. As a clinician point of view, how we should diagnose the chronic rejection? Patient symptoms and the blood test, of course, confirmed by the biopsy. Dr. Mugul explained the chronic rejection, how to be diagnosed, and how to treat and when to treat. So first of all, when the chronic rejection comes, there is a possibility of the yearly chronic rejection. The patient, if there is a poor drug compliance and the therapeutic level, if you look into that history, they are not maintained properly, it's not adequately controlled, then we can tell to them the strict drug compliance as well as we have to go ahead for the triple drug regimen and the mTOR inhibitor. That time, it will help for the slight possible reverting back to the normal function. And the role of methylprednisolone, and it is well clear, they said that there is no role of steroid therapy in the proven case of chronic rejection. And what is the long-term outcome if the chronic rejection? So that slowly the patient go to the biliary cirrhosis and the patients need the retransplant. But at the same time, when to do the retransplant? We shouldn't wait for the quite long time for the retransplant because the outcome of the retransplant in a chronic rejection in the more complicated situation, it is not good. Next slide, please. Yeah. So what could be the long term? I mean, before the chronic rejection patient getting into the cirrhosis, mostly of our chronic rejection patient, we can start to look into their poor quality of life, and the malnutrition will start, and the weight loss, and they are more prone to get sepsis. That's why if you diagnose chronic rejection, if you have tried various level of the immunosuppressive therapy, the modifications, and adding the mTOR inhibitor, but whatever the setting said, if the patient is the liver function worsening and the patient clinically worsens, that time we have to prime them for the yearly liver transplantation. Otherwise, the outcome will be good. Outcome will not be good. And what would be the immunosuppression? Suppose you are doing the retransplant. All the retransplant patients, due to the chronic rejection, they need triple drug regimen with always the low dose of steroid therapy, the long run. That is important. Next slide, please. Ladies and gentlemen, and there's a take-home message. ACR is common in post-liver transplant period. In general, it doesn't have the long-term impact on recipient and the graft outcome. Liver biopsy is optional to treat ACR in Indian setting, mostly as a living donor, and particularly in immediate post-liver transplant period. And maintaining tacrolimus level at a therapeutic level, it's a very important prior to the pulse therapy. And the continuation of the low-dose steroid therapy after ACR will vary based on their clinical and histological finding. If they have the recurrent or the de novo, we should continue. Steroid-resistant ACR is rare, but it's a really challenge to treat. mTOR inhibitors plays a useful role in the recurrent ACR as well as the yearly chronic rejection. Yearly retransplantation outcomes good in symptomatic chronic rejection episode. Thank you. Thank you so much for the kind listening.
Thank you, Joy, for that very crisp description of the presentation and treatment of various forms of rejection. I don't know how much time Sanjeev will allow us, but can I ask a quick?
Not a problem. Yeah, some quick questions if people are willing. It's late, but it's an interest. If people are willing, yes, sure, why not?
Can I ask a quick question, Joy?
Yeah, please, sir.
I mean, how do you see the role of rituximab in the treatment of rejection, especially B-cell mediated rejections, or any experience on that, or any literature that you would have come across?
Actually, we have involved in the only one case in the B-cell mediated with the rituximab, but the outcome is not the great. That is my personal experience, but I'm sure Dr. Sanjeev Sehgal and my colleagues will have the better experience with the rituximab.
I mean,
personally, personally,
we have actually, go ahead, Sanjeev. Sorry, go ahead.
No, guys, you're the chairman.
Go ahead. I mean, we have recently tried it. We have recently tried it in a patient whom actually was suspecting chronic rejection, but actually it turned out she has got de novo autoimmune hepatitis. It's a child transplant at the age of 7 years now. She's like 12 or 13. Transplant was actually done at Medanta, if I'm not wrong, but she follows up with me in Dubai. She's a Pakistani child. So interestingly, she had this combination of rejection, plasma cell hepatitis, but I would say very high globulins. And she has responded very well to rituximab. I mean, she was on all sorts of immunosuppression with lots of toxicities. So I'm not sure there's the first case we tried with, just some sort of, understanding. Yeah. Sanjeev.
Yeah, I think I agree with you what you're telling. And it's but the standard ACR, I think I would not, consider it all. It's a plasma cell rejection, autoimmune phenomenon, which is something which, you can consider on a case by case, which is a very valid point you put. I see Dr. Subhash has raised his hand. Maybe Dr. Gupta would like to add something.
I just want to share one or two sort of over the years, we've had few people who, they stopped taking their medicine and they had chronic rejection. And although they've not been with very high bilirubins and biopsy showing rejection, and we've actually sort of put in a stent and then lowered their immunosuppression. And I can recall at least 4 cases where they had dramatic response after that. I don't know. I just wanted to know the views of, or others who had similar experience, or is there something like that reported in literature? But I can recall at least 4 patients who had this kind of a situation. So intuitively in chronic rejection, you would like to increase immunosuppression, but actually they do much better. We found if you reduce it, and so there's some kind of sort of narrowing, or there's a sort of where the donor and recipient, that's why, where all the interfaces, that's where all the sort of rejection changes are. So I think the bile duct probably undergoes some edema or something. I don't know, but I just something that I wanted opinion or, raise this with my other colleagues.
It's a very interesting thing, Dr. Subhash, you have mentioned, and I would like to just know, we always talk about liver when you talk about rejection, but there's a bile duct interface, the donor duct and the recipient duct. And some of our patients develop strictures 5 years down the line, sometimes even a leak 5 years down the line, which I find very surprising. We always believe that the post-transplant strictures are early, all problems are early. So I don't know what happens there. It's something to do with rejection when you decrease immunosuppression or what, maybe someone.
Actually, I mean, we used to see a lot of this in the hepatitis C setting back in the day, because when we were transplanting a lot of hepatitis C, because you do get a lot of ongoing inflammation as well. I mean, this sort of addresses both points, both Kezar's and Dr. Gupta's. Kezar, so how sure are you that you're actually treating rejection with rituximab and not
I don't think I'm treating rejection. I think I'm treating autoimmune hepatitis. Her globulin is like 8 grams.
Yeah. So I think that might be a different entity.
Yeah.
But given Dr. Gupta, we've had similar experiences in patients who've presented with chronic rejection. And I think he answered his own question, because it's probably dactylitis with a low grade of biliary stricture and some obstructive cholangiopathy as well, which probably gets relieved with the stent. But I mean, without really changing the primary pathology,
Yeah.
So I think that it's.
This is a point. Yeah, this is a point which has been well endorsed. Again, I think we did actually publish also this CR experience, and when we're looking at the chronic rejection group, significant percent, I mean, fair amount, about 30-40% had actually biliary issues at the same time, and on their long-term follow-up. So I realized that there was an odd combination of those guys having bad biliary issues coming up later on, and then they're developing so-called chronic rejection. So the theory probably which we are talking, I think that some sort of biliary damage is there, which is we try to treat by stenting, percutaneous or endoscopically, and then they develop the graft dysfunction. And this point I think is pretty much clinical experience, I would say. Yes.
So Dr. Abha has asked a question, probably that is for Dr. Joy. How do you taper IV methylpred to oral pred after pulsing for ACR? What's your protocol?
So after the 3 dose, normally that's why I told, if there is not immediate post-transplant related in the ACR, if the patient is going to get a 1 gram once a day for the standard therapy of the 3 days, following that, the 4th day onwards, they will get the tablet form of the Viceron 20 milligram. So this will be there for the 2 weeks. After that, 2.5 milligram every week will reduce, and slowly over the period of 6 weeks to the 8 weeks time, it will completely taper.
Sure.
Yeah, I can see Anjali's comment on that. Rituximab is anti-BCL. Exactly, that's what I'm discussing. That what the Kaiser is selling is not actually ACR treatment. It's probably a plasma cell mediated, some sort of autoimmune which you're treating.
Because B cell is more important in AMR, antibody mediated rejection, and rituximab is functional there, not in ACR, not in acute T cell mediated rejections.
Yeah, totally agree with you. Joy, one question about this steroid tapering. Earlier we used to give 3 doses of steroids, 1 gram or 750 milligram, and then quickly come down to 60 milligrams of oral prednisolone and taper it. I mean, do you think there's any point in tapering a bit more slowly, like 500 into 3 days, 250 into 3 days, 125? Is there somebody who follows that? We did it a few patients, and we thought that they did well, but I don't know. It's a very, very small experience.
It's slightly vary from the center to center, actually. I mean, even the immediate post-transplant, also the steroid therapy and the tapering is varying from center to center. It's almost individualized. But in our center, normally it's 3 gram, means the 1 gram per day for 3 days. Next, the 4th day onwards, you will start with the tablet Viceron 20 milligram once a day, and then slowly the taper. That's working well. Meanwhile, so we are keeping the adequate tacrolimus. Tacrolimus will keep it around 6 to 8, and all the patient will be on the MMF. So once the steroid, once the ACR comes, they will be on the triple treatment for quite some time. Slowly, they will change to the double.
So when would you consider adding everolimus then for recurrent rejections?
Everolimus, suppose if the patient has associated renal dysfunctions, we already discussed, at that time we'll think about. But if you consider per se for the ACR, if the patient getting even sometimes, even after the pulse therapy, the liver enzymes will not be that much. Even though we are maintaining adequate TAC level, the liver enzyme will not come to the near normal range. At that time, the everolimus will helping, and those who have the recurrent ACR, that time also the everolimus, and the biopsy wise, that's what I mentioned. Sometimes the yearly chronic rejection biopsy we are getting, but if you are adding on the everolimus and if you are seeing the outcome, it's showing a very good response.
So that's quite intriguing, because mTOR in ACR is something that perhaps isn't that commonly used actually. So there are 2 issues that sort of immediately come to mind. One is that the long half-life of these mTORs, right? So normally it takes a few days for the mTORs to get going. Where would you sort of, if you had a protocol, where would you start your mTOR? You know, like if, for example, you had an ACR, you gave a PRED a pulse, and then you didn't get, say, an acceptable response in 3 days. Where do you see, when would you start everolimus or sirolimus, whatever you're using?
Usually the everolimus, we will start, if there is no much response in the follow-up period. That's the thing. So they will do the once in, I mean, twice, usually the patient will come for a follow-up after the pulse therapy, weekly twice. So weekly twice, they are coming, that time itself, if there is a good response, we won't consider mTOR. Otherwise, there is no much response and the adequate TAC level is there, then we will consider the mTOR. That it's working very well. And Dr. Dharmesh is here. Actually, do you have, Dharmesh, your opinion?
I think my take on ACR is completely different. So ACR is of two types, one which is enzyme dominant and one which is cholestatic. And I treat the two differently.
I think we can conclude the day one proceedings now, and I would like to thank all the speakers and chairpersons and delegate for their active participation and excellent discussion. And over to Dr. Sanjeev Sagar.
Well, I must thank everybody because we are still like wanting to have more discussion, but our system now will not permit going beyond 9 at this time of the day, and it still speaks of the fact that despite this being a very specific and uncommonly discussed topic, immunosuppression in transplantation has really been of impact to all of us. And we are excited to discuss this. Kindly join tomorrow at 4 o'clock sharp for some very interesting talks. We have leading international faculty, national faculty speaks in clinics and challenges and so on. And it would be a delight to have you all. Please join, please share it with your colleagues and students, because this is an opportunity for those who are into the transplant and new into the transplant. They really can learn, and we all can learn, educate ourselves. It's always a learning process which goes on. So my sincere thank to each and every speaker, faculty, delegate who has been present today till late today. And I thank you all, and I invite you again to join tomorrow at 4 p.m. sharp. Thank you very much. Thank you.